Okay, welcome everybody. It's my pleasure to introduce Dr. Leo Ocuin. He's an assistant professor of surgery at University Hospitals in Cleveland. He trained at, went to undergrad at Brandeis, trained for his medical degree at Tufts. He did his general surgery residency at Emory University. During that, he did a research fellowship as well at Memorial Sloan Kettering. He completed a fellowship in complex general surgical oncology at the University of Pittsburgh, as well as completing an additional fellowship in pancreaticobiliary surgery at Mayo Clinic. Prior to joining UH, Dr. Ocuin was a site-based medical director in the Division of Hepatobiliary and Pancreas Surgery at Atrium Health Carabas. He is a member of several professional societies, as well as an editor of several high impact medical journals. I know at UH, he's one of the residents' favorite attendings to work with, as well as a valued research mentor. And so we're really excited to hear his talk on the management of hepatobiliary metastases and colorectal cancer.
So really appreciate the invitation to speak to everybody tonight. So I'm going to talk about the surgical management of colorectal cancer liver metastases. I don't have any relevant disclosures. So what I hope to cover is a little bit of the background and significance, scope of the problem. We'll talk about metastasectomy or resection, in terms of definition of resectability, some technical considerations and oncologic considerations. And we'll spend a little bit of time at the end talking about hepatic artery infusion pump therapy for anatomically unresectable and resectable disease. So as probably, I don't need to tell this audience this, but colorectal cancer is the third most common cancer in the United States, and there's about 150,000 cases a year. It's also the third most common cause of cancer death, with about 53,000 cases per year. Overall, about 60% of patients are alive at 5 years after the diagnoses, with a much obvious higher survival rate in patients with localized disease as compared to metastatic disease. As far as colorectal cancer metastases, the liver is the most common site of distant spread and often the only site of distant spread. About 25% of patients with a new diagnosis of colorectal cancer are going to have synchronous metastatic disease, again, with the liver being the most common and often only site. And overall, all comers, 50 to 60% of patients will eventually develop liver metastatic disease. Why is this important? Okay, so liver metastases are the most common cause of death from colorectal cancer. Metastasectomy is the best opportunity for patients to achieve long-term survival and cure in a subset of patients. And then, sort of in parallel to this, colorectal cancer liver metastases are consistently mismanaged, and multidisciplinary care is essential. So this was an editorial published in JAMA Surgery now 2 years ago, from the Sloan Kettering group, and they go into a little bit of why, sort of the historical mismanagement of this problem. So between 1991 and 2001, only 6% of patients with colorectal cancer liver metastases actually underwent resection. That's improved more recently to 15%, but that's still only a fraction of the total number of patients that could potentially derive benefit from a surgical approach. So why is that? And there's just a high frequency of anatomical and biological resectability assessment being made by non-experts. So as an example, this is a paper from the Tufts group, where they took 72 patients with colorectal cancer liver metastases who, after multidisciplinary tumor board discussion, were slated for palliative chemotherapy. There was no input from a trained liver surgeon. So 2 liver surgeons were blinded to the treatment decisions, and they reviewed all pertinent imaging. And what they found was about 44% of patients who were assigned palliative chemotherapy felt to be unresectable, or actually potentially resectable upon independent review. As another example, this was a publication now 7 years old. This was a survey in Michigan of medical oncologists. And one of the questions, or the question, sort of the main question was, how often do you consider the following to be contraindications to liver resection for colorectal cancer liver metastases? So the majority felt age played a role in this. Again, the majority felt medical comorbidities played a role in this. Prior liver resection, again, majority felt that this was something to consider as a contraindication. Greater than 4 metastases, almost a high majority, over 50% thought either often or always a contraindication. Approaching 40% of respondents felt that any tumor greater than 5 centimeters was a contraindication. 42%, 43% felt that bilobar disease was a contraindication. And what I'll take you through over the next, hopefully I'm not going to take your whole hour, but we'll go over why this is all not correct. Bill Silen, who recently passed away, was actually an anatomy professor I had in college. I had no idea who he was at the time, but he published this editorial in Archives of Surgery in 1989. There was a lot of skepticism towards hepatic resection from colorectal cancer liver metastases. He felt, at least at the time, the morbidity and mortality of liver resection offset any advantage. And essentially the current evidence does not support hepatic resection, although, sort of the catch-all phrase, with good patient selection, some patients might benefit. About a year later, a paper came out in British Journal of Surgery where they looked at about over 1,000 patients with colorectal liver metastases. This Kaplan-Meier curve shows the overall survival. This curve where median survival didn't approach a year. These were non-operatively managed patients. And this Kaplan-Meier curve represents patients who were managed operatively with negative margins. And this middle curve, which is something we typically don't do, were patients who had liver metastases that were debulked, but not completely. So there's an association here between complete metastasectomy and improved overall survival, with the median survival approaching 3 years. This is a more pertinent survival curve. So this is when they took the patients who had complete clearance, margin negative resection. These 3 survival curves represent patients with solitary metastases, multifocal metastases, or bilobar metastases. So essentially they're all overlapping. If you can clear the liver, and this is with surgery alone, no chemotherapy. This was 1990. This is before 5FU. Patients are living about 3 years median survival. So this sort of changed the opinion. And there's a famous saying from Murray, I think it came from Murray Brennan, but if you throw a brick through a window and it goes up, you don't need a randomized controlled trial. So this is one of those rare situations where we have a standard of care that is widely accepted without level 1 data. So surgery is the only option for cure with patients with colorectal cancer liver metastases, and any RCTs would be, at this point, felt to be very unethical. So it's never actually been studied head to head. So how do we approach patients with colorectal liver metastases? So this is sort of my approach. I think you can apply this to any cancer, really, but you have to ask questions about the patient's condition. Does the patient have comorbidities or other factors that will limit tolerability of treatment? Biology, which we know is, sort of the ultimate arbiter here, but are there characteristics about the underlying cancer that project treatment will not confer any oncologic or physiologic benefit? And then the last thing I typically assess is anatomical, which is, the question is complete clearance of metastatic disease burden technically feasible? Can the patient be, separated from the tumor? So removability and resectability are not the same. So removability is you can technically separate patient from tumor, but resectability is asking the removability question, but also factoring in the conditional biological constraints. So, sort of this is I think applicable to really any cancer oncologic situation, but I would define conditional resectability as patients with a good performance status, typically younger. There is something about crossing that 80-year-old threshold where patients just don't have the same physiologic reserve, but that's not on its own ever something I consider on its own. Like I have, if a patient's ECOG 0, fit, they play golf, whatever, they're very active and they're 85 years old, I don't count the 85 against them. I just, it's in the back of my mind, but it would never be a reason that I would not offer resection. They have minimal or well-controlled comorbidities. They're not showing up to the office with a lot of weight loss or cancer-related symptoms. Conditionally borderline patients, these are the patients that have compromised performance status. They were doing well up until they were diagnosed. Now they're spending a lot more time sitting around, sedentary. Again, older age, part of the factor. They're deconditioned. They have multiple but possibly optimizable or controllable comorbidities. They're going to come in malnourished. They'll have experienced some prodromal weight loss, or they have new or poorly controlled cancer symptoms. And then unresectable was sort of self-explanatory. These are the patients that can't tolerate a haircut, right? Like they're not good operative candidates. You're going to hurt them if you try to be aggressive. These are patients where you need to initiate, palliative care, end of life decision making, potentially optimize them to some kind of maybe palliative chemotherapy if you can make big improvements. But these patients are never going to come to getting to the OR, and that's okay. It's just you have to have that honest conversation with those families, and it's still important for the surgeon to make play a role in this determination. As far and part of the problem is the non-expert weighing in. It patient never makes it to the surgeon for reasons that I outlined earlier. So what about biological resectability? So this is the most widely cited surgical paper ever written from the Memorial Group. So they described the clinical risk score, which obviously, there's more nuanced ways of doing it these days, but this still holds its water, I think, pretty well. But they looked at 1,000 consecutive cases, and they looked at predictors of occurrence, controlling for other clinical treatment demographic factors. And what they found was patients with greater than one tumor, a CEA of greater than 200, tumor size greater than 5 centimeters, a node positive primary, or a disease-free interval less than 12 months, all associated with earlier recurrence. And when they do, it's a pretty simple scoring system. Each thing gets 1 point. And when they applied that clinical risk score to that cohort of patients, patients with a clinical risk score of 0, had almost 93% 1-year survival, 60% 5-year survival, median overall survival of over 6 years. And when you got down to a clinical risk score of 5, 30% of these patients weren't alive at 1 year. Median survival was about 2 years. And the demarcation appears to happen right around from when you cross from 2 to 3. The median overall survival really goes down, and so this has sort of become this sort of a cutoff that's been demonstrated in other studies. So when they looked at the whole cohort, the same paper, when they looked at the entire cohort of patients, just all comers. The median overall survival from liver resection was almost 4 years and approached 6 years from the initial primary resection. When they looked at it by the number of tumors, again, differential survival curves once you got to greater than 4, but still patients are approaching 3-year median survival even with 4 tumors, and all the way out to 4 years with 1 tumor. And then looking at the long-term outcomes, this was a more recent paper from the MSK group that looked at actuarial 10-year survival after hepatic resection of colorectal liver metastases and looked at factors that predicted lack of cure. So again, if they took all comers, so this was, I think, 1,200 patients, 1,211 patients, all comers, median overall survival was about 5 years. And the 10-year overall survival was about 35%, which is pretty impressive when you think about it. When they stratified by that clinical risk score of 0 to 2 or greater than 3 or greater, you can see a differential survival curve. Patients with a 0 to 2 median over survival over 6 years, whereas patients with a higher clinical risk score lived about 4 years, but still pretty good. When they looked at sort of single data points as far as features of a patient's cancer, what the 10-year disease specific survival or cure rates were, they found that a CEA greater than 200, greater than 10 liver metastases, the presence of extrahepatic disease or positive resection margins on the metastasectomy, all were associated with cure rates of less than 10%. So just to sort of summarize the different clinical scenarios, and by no means does this encompass all scenarios, but if you have a patient with fewer than 4 tumors, no extrahepatic disease, you can get negative margins, and their CEA less than 200, these patients have a real possibility of cure. Patients with more than 4 tumors, no extrahepatic disease, but higher CEA levels, cure is still possible. And then patients with greater than 10 tumors, extrahepatic disease, positive margins, high CEAs are generally unlikely to cure them. But that being said, even if cure is unlikely, metastasectomy still confers the possibility of long-term survival, even in these biologically high-risk scenarios. So by no means is a patient with 10 tumors someone I would never consider offering surgery to if they were otherwise medically appropriate for surgery, et cetera. You can still help these patients more than just with systemic therapy alone. So let's talk about anatomical resectability. So the general criteria, so patients need an adequate future liver remnant with preserved hepatic arterial inflow and portal venous inflow and hepatic venous and biliary outflow. Things that affect anatomical resectability is the pattern of metastases, so size, number, location, distribution, and overall disease burden as compared to the non-tumor bearing liver. But this again is something, and this is within the NCCN guidelines, that should be evaluated by a hepatobiliary surgeon. You have to have an eye for this. There are there's a lot of outside of the box thinking, and it can't just be a rigid definition that somebody has 8 liver tumors in each segment and they're not resectable. Those patients are still potentially resectable if those 8 tumors are small, ablatable, or wedgeable, and you can preserve an adequate liver remnant, et cetera. So it's easier to define anatomical non-resectability, which would be a margin negative resection would require resection of all 3 hepatic veins, both portal veins or the retrohepatic IVC, or leave fewer than 2 adequately perfused and drained segments. And that's not a super common scenario that we see just off the definition, but But again, you have to have an eye for it. Liver surgeon has to review the scans. There's been an increased emphasis over time on parenchymal sparing surgery. So again, from the Sloan Kettering group, they looked at over 4,000 resections for malignancy over about a 20 or so year period of time. And if you look at they divided into sort of 3 time periods. And if you look at the early time period, 2/3 of patients were getting major hepatectomies as compared to about 1/3 more recently. The 90-day mortality was lower in the more recent cohort. Major complication rate was about the same. They're doing more ablations in the more recent cohort. When we look at parenchymal sparing surgery versus anatomic liver resection for colorectal liver mets, this is a review by Tim Pollock and colleagues. They showed that the 5-year overall survival was the same. So there's been a shift to, when you can preserve parenchyma, that's what we favor. So what about synchronous colon and liver resections? So this is a study, I'll show you more of the details in a second, but from Mayo Clinic. But you sort of have to think about the liver and the colon, and define the higher risk colon resections and the higher risk liver resections. So low risk colorectal operations, generally speaking, would be right-sided approaches, a left colectomy with no diversion, a straightforward LAR. Higher risk colorectal operations would be a left colectomy with diversion, total abdominal colectomy, proctocolectomy, or an APR. Lower risk liver resections would be a partial hepatectomy or a left hepatectomy. The higher risk liver resection would be a right-sided right hepatectomy or any extended resection or trisectionectomy. So the Mayo group looked at their institutional series of synchronous resections, and what they showed is when they combined a major liver with a major colorectal procedure, the odds compared to a minor with a minor, there was about a 5-fold increased odds of a 90-day mortality, 4-fold increased odds of some colorectal comorbidity, 7-fold increased odds in some liver-related morbidity, and about a 3-fold odds increase in total morbidity. Whereas when you combined a major with a minor, or a minor with a major, you didn't really see, there was no significant increase in the odds of a 90-day mortality. So typically, at least, I think it's not that controversial, but I'll certainly do a major liver with a minor colorectal or vice versa. And I try to avoid combining 2 majors. Those are typically the situations where we'll do a 2-stage approach based on symptoms from the primary tumor. So if you have somebody with a very symptomatic rectal cancer and liver metastases, that might be somebody who needs, diversion, and then local regional therapy for their rectal cancer, TNT, and then you focus on the liver later. Whereas somebody with an asymptomatic primary but needs, a very low LAR or an APR, but they need a right hepatectomy, you might do a liver first approach in those patients. Or if they have bilobar disease, you can stage the colon resection with clearance of the future liver remnant, and then address the major hepatectomy as the second part. So what about the future liver remnant? So typically speaking, somebody with a completely normal liver only needs about 20% of their liver to have normal liver function. Really, any of the patients that we see, they're typically a little older. Most of them have seen some chemotherapy. They're going to have some degree of steatosis, whether it be just from dietary or chemotherapy associated. Those patients are going to need at least 30% of their future liver remnant. And then patients with really unhealthy livers usually need, 40%. I think patients with cirrhotic livers need way more than 40% of the FLR. So how do we optimize the FLR? Portal vein embolization would be the gold standard. More recently, hepatic venous deprivation has been described, which is a combination of portal vein embolization and hepatic vein embolization. It induces greater hypertrophy than PVE alone, and it's safe. And then I'm sure most of you or all of you have heard of ALPS, which generates much faster hypertrophy of the FLR than PVE. Outside of experienced centers, there's a real morbidity and mortality associated with this procedure. And then, one thing I especially don't like about ALPS is it doesn't allow sort of that tincture of time. So typically a PVE, you wait anywhere from 4 to 8 weeks for the liver to hypertrophy. Typically the patient's off chemo at that point. And you have that little bit of tincture of time to allow the patient to declare themselves with, either new metastases or extra hepatic metastases. Whereas with an ALPS, usually you're doing back-to-back procedures within a week or so, and patients don't have time to declare that distant disease. So there's a certain number of patients that maybe would have never benefited from a major hepatectomy that you can unmask with sort of the embolic techniques as opposed to ALPS, which and that's been shown in some of the prospective and retrospective studies that there's just a higher rate of early distant recurrence because they missed those patients because they were already sort of committed to the procedure. Why is the FLR important? This is from MD Anderson, who's really sort of pioneered this technique. But the rate of hepatic insufficiency in their series of about 100 and 200 patients or so, about a third of patients with an FLR of less than 20% had hepatic insufficiency, and there was a 10% mortality from liver failure on patients who had inadequate FLRs, which went way down, patients with adequate FLRs. So how do we do a PVE? This is actually not how we ever do a PVE by accessing the left portal vein. Typically, the right portal vein is accessed and a balloon is inflated distally, and then have a side hole proximal to the balloon, and you embolize either with gel foam, coils. There's a variety of embolic substances that we use to occlude that right portal vein. And what it does is redirects the portal venous flow to the future liver remnant, shifting the hepatic functional reserve to that FLR, causes atrophy of the embolized liver, hypertrophy of the remnant. And if your interventional radiologist likes you, they'll leave some space between the bifurcation because it can get really, really sticky here if they don't. So in this series of patients, again from the Anderson group, patients who had adequate FLRs had lower complications rates, lower 90-day mortality from liver failure, much lower rates of hepatic insufficiency. And the three things we typically look at are the kinetic growth rate with a cutoff of 2%, future liver remnant 30%, and a degree of hypertrophy of 7.5%. So what this tells you, if you can achieve these benchmarks, is basically, is the future liver remnant healthy enough? Because I think if a patient fails to get to these endpoints, that they're telling you a lot about their physiology and their liver physiology. And so maybe an aggressive hepatectomy, should give you some pause. But again, the major complications go way down when patients achieve these benchmarks, and hepatic insufficiency goes way down. And then I've never seen a study with a 0, but they actually had no liver-related mortality in patients who achieved these benchmarks. So everything I've talked about to this point, as far as metastasectomy, et cetera, all of the evolution of liver surgery obviously would not be possible without the development for chemotherapeutics, and that's a whole separate talk. So I'm not really going to go into that, but I put this up just to sort of show the timeline. 5FU was first came out in 2000. For now in the MSI high patients, we're moving to immunotherapy more recently. There's probably, there's another 6 years here that I haven't put on this chart, but the reason I put this up is because hepatic artery infusion pump therapy was first described in 1984. So whenever I talk about this, certainly with the, there's a misconception that this is new. And it's really not new. It's been around for almost 40 years. So the idea here is that liver metastases are perfused by the hepatic artery, and the normal liver parenchyma is perfused by the portal vein, and less so by the hepatic artery. So you can basically physiologically isolate the liver, with an arterial infusion catheter and treat liver tumors with much higher concentrations of chemotherapy. So FUDR, or floxuridine, is the active form of 5-FU, and it has the ideal half-life of less than 10 minutes, and we see 100 to 400-fold higher concentrations within the liver, and it has about a 99% hepatic first pass metabolism, so there's almost no systemic side effects. So that's sort of the ideal drug that's been used for several decades now with HAI. So principles of HAI. So common misconception that it's pump alone. So HAI is always pump plus systemic therapy. The systemic therapy options are usually doublets, so FOLFOX, FOLFIRI, or OXIRI. And we never combine pump with Avastin. There was a phase 2 trial where the Avastin component of the treatment was terminated when they saw that 20% of patients had developed biliary sclerosis, up from a normal of about 5%. The pump chemo is comprised of FUDR with dexamethasone. A cycle is every 2 weeks, and patients typically get up to 6 doses of FUDR, although most patients don't get all 6 doses. The indications in the colorectal space, most commonly unresectable or potentially resectable convertible patients. And there's also a space for adjuvant pump therapy, which I'm not going to get into tonight. This is an older study, CALGB 9481, which was published in the early 2000s. It was a multi-center randomized controlled trial of 135 patients who were randomly assigned to HAI alone or systemic therapy. At the time, 5-FU was the only thing around, with the primary endpoint of overall survival. And what they showed was an improvement in median overall survival of about 4 months with HAI. And an improved hepatic progression-free survival of about 3 months. More recently, the UPMC group looked at HAI combined with modern systemic therapy using a case control setup. Patients with unresectable colorectal cancer, 40%. Had KRAS mutations, and the median number of tumors were 15. And they all again showed an associated improvement in patients who got hepatic artery infusion pump plus modern chemo as compared to modern chemo, about doubling the survival time hazard ratio of 0.39. What about conversion therapy? So this was published about 7 years ago now. This is a phase 2 trial from Sloan Kettering looking at patients with unresectable liver metastatic disease burden. About 2/3 of them had already gotten second or third line chemotherapy. Median number of tumors were 14. Patients were treated with, again, HAI plus systemic therapy, and they looked at a primary outcome of conversion to resection. So what they found was chemo-naive patients had improved overall survival as compared to those who were previously treated. At least at the time of publication, they didn't even, the chemo-naive patients didn't even reach a median overall survival. 76% of patients responded, and about 50% of patients converted to resection, again, higher in the chemo-naive arm. I think it was about 57% in patients who were chemo-naive. And the overall survival was 38 months, and as I mentioned, was not reached in the chemo-naive set of patients. They went back and looked at the longer-term results of this study, and what they showed is in the patients who were converted and underwent an R0 resection by 1 year from initiation of HAI, the 5-year overall survival was over 50%. And patients who just got HAI but no resection had about a median overall survival of about 2 years. Again, again, this is probably its own talk, but just for to contextualize this for you guys, and a lot of this comes from retrospective data at this point, with a large prospective trial in the works through ECOG and NCTN. But HAI plus systemic therapy in the first-line setting has, approaching 90% response rates compared to 60 to 80% for systemic therapy alone. In previously treated patients, HAI will have a 70 to 80% response rate as compared to 10 to 20% of patients who get second-line systemic therapy alone. And then even in patients with refractory disease to systemic chemotherapy, about a third will respond to HAI. In the first-line setting, median overall survival was 77 months. In some of the older, but using modern chemotherapeutics, the median overall survival of patients with metastatic colorectal cancer who never get surgery is about 2 to 3 years. The R0 patients who get HAI and undergo R0 resection don't have a median survival. Previously treated patients live about 30 months, and refractory patients live 20 months, which again, that hasn't, these are far longer than what we see in patients with refractory disease who just get their second or third line setting. So essentially, we think that compared to the next line of systemic chemotherapy, HAI is probably always better than the next line. Again, and as far as patient selection and things like that, this is not for every patient, but it just should be a consideration, especially at programs that offer centers that have an HAI program. A little bit about the pump. So this is the Intera 3000. It's the only FDA-approved drug delivery device for HAI. This is essentially the remanufactured Codman 3000. In 2018, Johnson & Johnson discontinued manufacturing the Codman pump. HAI centers that were active at the time switched to a Medtronic pump that was not FDA approved. And Tera took over the patent, remanufactured this pump from the ground up. So it's now gone through an FDA approval process, but it has a propellant chamber that's Freon based. So at body temperature, the propellant, ideal gas law, Freon converts from liquid to gas, and it compresses this drug reservoir, and drug flows out through the catheter into the GDA at about flow rate of 1.2 to 1.4 mLs per day. There's 2 needles that access this pump, a special bolus needle we use for pump studies that has a side port that accesses the bolus chamber, and then the refill accesses the main drug reservoir chamber. This is a schematic. So, we do these robotically and open. But essentially, it's a laparotomy. Gallbladder is removed. A few of the portal nodes are removed. The GDA is accessed, and the catheter is tied in place right at the junction. common hepatic artery GDA bifurcation. Typically, we place the pump in the left lower quadrant, so it's out of the way of the liver, so there's no artifact when we get scans, either CTs or MRIs. So this is in situ view of our first pump implant back in April. We typically will study the pump, post-op day 2-3, using technetium-99 macroglutamate albumin, or it's called a HAPS. And what we want to see is liver-only perfusion on the SPECT with no extrahepatic perfusion to the stomach, duodenum, or the head of the pancreas, which cause ulcers, GI bleeds, pancreatitis. So that's a good HAPS study there. Our program at UH launched in April. We've placed 8 pumps to date. We have 2 pending. Next month, we have a technical success rate of 100% and a feasibility rate of about 90%, defined by at least 1 cycle of FUDR, and we've had no cases of biliary sclerosis. We think the best data, which would be indicated by that long-term series from Memorials and the chemo-naive patients. So this is one of our chemo-naive patients who presented with a pretty significant hepatic metastatic disease burden and a left colon cancer. So we did a combined left colectomy and implanted an HAI pump, and this is after just 2 cycles of FUDR. You can see the huge radiographic response in the liver. So this is a patient who might be on his way to converting to resectability. So we'll see in another couple of cycles, but we've seen good response rates in most of our patients. And then I mentioned there's a phase 3 clinical trial in the works through ECOG. There's over 50 institutions as part of the HAI Consortium Research Network. So while this historically has been a treatment that was out of Memorial Sloan Kettering, as we've sort of reached critical mass with lots of centers starting pump programs now, both national and international. So we hope to be able to improve access to patients. And that's all I have for this. So thanks for the attention, and I'll take any questions.
Thanks for an excellent talk, Dr. Ocuin. We will take any questions or any questions in the chat if you guys want to ask him anything. So I don't see any. Matt, do you see any on Surgeon?
Nothing on Surgeon at the moment. I actually had a quick question. Why do you think that there has been such a poor uptake in physicians' impressions about how to treat metastatic colorectal cancer?
I mean, I think there's just just a general nihilism. So if you look at that survey-based study I showed earlier, I think a lot of people, look at a lot of those factors are right out of the clinical risk score. So more than 4 tumors, a tumor greater than 5 centimeter. I think it's just, I don't mean to be, just ignorance to what's possible. Lack of access to a high volume hepatobiliary surgeon. I think even at our center, the folks will say from time to think like, oh, this is a lot of surgery to offer the patient. And we don't just do this, we don't do a major hepatectomy, with a synchronous colectomy or two. There's a lot of nuances and judgment that go into making these decisions for patients, but they should be getting made by experts. And on paper, some of these patients might seem marginal, like, they're not a good candidate. But at the end of the day, you got to get those patients to a center with an expert, and let that expert weigh in, because the outcomes are really good in centers that do a lot of this, by surgeons who do a lot of this. We don't see a lot of complications. We don't see a lot of 90-day mortality. We achieve, not often cure, but we buy a lot of time, either off chemo, and then you can hit a home run every now and again. We're not sophisticated enough to know which patients yet, and we need to get to that point to know, prospectively, who's going to benefit from an operation. But that 1990 study I put up, right? I mean, patients are, about 10 to 20% of those patients were living 5 years with nothing else but surgery, right? So there's a subset of patients out there that really do derive a ton of benefit. And so it's really, it's, I think, educating the community medical oncologists, community GI folks who may not be, either have their biases, or just haven't, had a lot of exposure to, to that high volume level of expertise. So I can tell you at both of my jobs, I spent a ton of time doing community outreach to those referring providers, because it might not be at the forefront of their mind. They're just so used to just, giving chemo or sending patients for Y90 or, TACE or whatever. But, a lot of these patients are actually potentially completely cytoreducible, completely clearable, and those patients are going to derive the most benefit.
Okay. I've got a question from Olga Garcia, and actually a related question from her. When doing combo cases, liver first with ultrasound. I'm not sure if she's referring to liver before colorectal, or if you always use an ultrasound prior to doing liver cases. And then she also asked, I'm also curious from your experience, how much do most liver surgeons enjoy or hate doing colorectal cases versus primary biliary or liver cancer? Does it matter?
So, I mean, if I'm understanding the first question, typically, I mean, especially if it's a major hepatectomy, typically if we're doing a planned synchronous operation with a major hepatectomy, typically I'll do the liver first, because if that doesn't happen often, but if that somehow went off the rails, got into a lot of bleeding, a lot of hemodynamic lability, et cetera, it might be a good time to bail on the colon, especially if it's not symptomatic. Because otherwise you're looking at potentially bringing up an ostomy or something like that, and you just go back. The primary is unlikely to be the driver of oncologic survival. It's really the liver. So I usually go first. I don't really, I mean, I personally enjoy all the cases. I don't love the multifocal cases where you're doing a bunch of wedges and ablations. But you do what's, I think it's always enjoyable to be in the OR. I don't think it really, I think it's all enjoyable surgery at the end of the day. Some more enjoyable than others. I see another question about MIS approaches. I think there's definitely a role for MIS approaches. I try to take a practical approach. I'm not a zealot by any means in terms of we have to do this. I personally won't do a laparoscopic right or a robotic right hepatectomy, because for me, just my practice, I keep patients after that operation in the hospital for a certain number of days. And having been at centers that do a lot of MIS major hepatectomies, have not seen those patients go home any sooner on a routine basis. So if you can do it, I think there's certainly a role for it. I'm a little bit more conservative when it comes to when it comes to this. I think you just do the safe operation for the patient, and sometimes that's an MIS approach. Certainly, ablations, left lateral sectionectomies, straightforward wedges. Especially if you're combining them with something that could be done, like a laparoscopic right or left colectomy or LAR. I mean, I think it's certainly reasonable, but not for the sake of keeping the patient on the table longer. These are big cases, no matter how you look at them.
So yeah, Vanessa writes,
Yeah.
your view, what makes patients high risk versus a low risk hepatectomy and colectomy? Is there a situation where you would ever consider doing both upfront? High risk, both upfront.
Yeah, I mean, so from the liver standpoint, the rate of post-hepatectomy liver failure and dysfunction is going to be higher with a right hepatectomy, because the right side is typically, about 60 to 70% of the liver volume. So that patient's just at baseline higher risk of liver-related morbidity after a right-side approach, and then any extended resection. Whereas a left hepatectomy, even though it's a lobe, you're only taking 30 to 40% of the liver volume. So the risk of post-hepatectomy liver failure is pretty low outside of some, vascular catastrophe, unknowingly taking the bile duct or something like that. And then obviously non-anatomic resections, ablations, et cetera, are all lower risk procedures as far as patients having a liver-related mortality, liver failure, liver insufficiency. And then I think the higher risk colectomies, I mean, you guys know this better than I do, but typically the left-sided anastomoses have higher leak rates. So you just have to be cognizant of it. But I would certainly, if it was a young, healthy, fit patient, where you're not really concerned about, like more than normal about blood supply issues and things like that. I will, but it's a case by case basis. I typically try to avoid combining the majors, just because, even in, things can go wrong, and there's really just there's no urgency to expose a patient to higher risk. It's just, the conservative approach. If you're doing like an APR with an extended right hepatectomy, I mean, you're putting the patient at an unneeded risk. Even though I think the overall mortality rate's still pretty low. I mean, you're going from 1-2% mortality to 5-6-7% mortality at 90 days. I think that's just unnecessary. I just soon take that patient back for a second operation, and not expose them to undue harm. The molecular signature changes. Typically, I mean, I think there's a lot of heterogeneity. Typically, the mutational status. I didn't get too much into that, but we know KRAS mutated patients are going to have a worse overall prognosis, but they will still benefit from a liver resection as compared to no liver resection. BRAF patients are a little bit, those are probably the highest risk cohort of patients. I could certainly tell you I wouldn't ever pump a BRAF mutated patient. We almost never do that. And then as far as considering, a metastasectomy for limited disease, consider it under the right set of circumstances. Again, the patient's got to prove their biology to a degree. You're not just going to take those patients up front.
Shrey Modi also, is HAI.
Yeah, HAI being used with patients. So the regimens that have been studied with HAI are the ones I mentioned: FOLFOX, FOLFIRI, and OXIRI. so that's really the only, those are the systemic, so we don't typically combine biologics. It's certainly not Avastin. I know some medical oncologists will combine some of the other EGFR inhibitors. I don't think immunotherapy has been studied well, certainly not in a prospective trial setting. And typically, I would say this might go on at some of the more experienced centers, but I can't comment on that. Certainly at our center, we're being very conservative since it's a new program, so we're not going off too far off the beaten path. We're doing what's been studied and what's safe. And then let's see. So HAI Center up and running. That it takes a lot of work. So it's very institutional dependent. What I would say is, I'll just speak to what we did at UH. Is we identified a medical oncologist who is very interested in the colorectal space and HAI. So Eva Selfridge is she's the co-lead of the program with me. And then what we looked at how Sloan Kettering does it, and then we said, that's been the busiest, most successful site, and so let's model our program after that. So there's multidisciplinary input, but she owns the chemo space of that, obviously. But we work together, and I sort of manage the surgery, perioperative aspect of it, and then but we work together. But you need buy-in. What I would say again, that's a lot of the community outreach I did to get buy-in, because some medical oncologists are very skeptical of HAI. Because historically, the only center that's shown it to have any efficacy is Memorial. And that's a combination of there weren't a lot of other centers doing it, and the centers who were doing it were not getting the same type of patient. So Memorial will get a much higher proportion of chemo-naive patients who are seeking this out, just a healthier phenotype of patients. So they're seeing far more benefit, whereas the newer centers are probably seeing more of the heavily pretreated patients, and it just takes time to get the referral patterns to evolve. We're seeing these patients earlier, and then the subset of patients who may derive a benefit from HAI, you see those patients sooner. So that's why it's a long process. You need buy-in from the cancer center, infusion center. You have to have the infusion nurses in service line, pump access. I do have colleagues that sort of run the program by themselves, and they're calculating FUDR doses and doing all the refills, or they have an APP who's managing it. I think that's a ton of work, and if you can get sort of more broad-based institutional support, and divide the workload, so that medical oncology is sort of owning the chemo side of things, it certainly frees up bandwidth for me to focus on other things and not just the pump patients, because as you accrue them, it gets very, very busy. When you have one or two, we currently have seven active patients. We're about to have 9 active patients. So and that's just going to continue to grow. So it can get very, very busy. So if you have support, and obviously have a good working relationship with the device reps, and they're just the wealth of education and resources for medical oncologists, OR staff. So you have to have it's multifaceted. And then I'm looking at the next question. So we're using ctDNA more as far as recurrence. There's been 2 big randomized trials now that show there's no additional overall survival benefit to more chemotherapy after complete metastasectomy. So there's the older study by Nordlinger, I think EORTC, I forget the numbers, and then a more recent study out of Japan. So using those two sort of, more chemo is not necessarily better. There's improved progression-free survival, but not improved overall survival. There's patients who can get off of chemo for a period of time. And what we're certainly doing it at UH, if we patient who's gotten some perioperative chemo, we get them to surgery, clear the liver, whether or not primary at the same time, or maybe it's a metachronous primary, it's already been resected. A lot of those patients will just start checking, surveillance CT scans, typically like a liver protocol CT, and ctDNA. And if they have an undetectable ctDNA, we leave those patients on active surveillance, and that's becoming more and more the practice, and saving the chemo for when you really need it. And that's, again, one of, I mentioned this in passing in the talk, but chemo for colorectal cancer is generally effective for the majority of patients, certainly in the first line setting. And that's why we can do this aggressive liver-based approaches, or in the peritoneal surface space, because you have good chemo. Like, that's why we don't do these operations for patients with metastatic pancreas cancer, because the chemo actually pretty bad, 20-30% response rates and things. So once you have good drugs, and you can achieve response rates and durable control, you can think about cytoreductions and more aggressive liver-based approaches. And as far as liver first versus primary first, again, it's sort of like a 2x2 table, more or less. It's what liver operation do you need to do? What colon operation do you need to do? And is the colon primary symptomatic or not? So if the patient has a very symptomatic primary, you have to probably do something about it. Whether it's, if it's a right-sided, probably resect. If it's left-sided, probably divert. But typically, that's not the case. And typically you can prioritize the liver. And then if it's a situation where there's bilobar disease and you need to somehow optimize the FLR, I'll usually combine clearance of the liver remnant with one of the colorectal surgeons clearing the primary, patient recovers, and then we optimize the FLR and come back for a second stage hepatectomy. For rectal cancers, typically again, depending on liver disease burden and what we need to do, I'll push for a liver first approach in those situations. But it's really, really individualized to the patient as much as you can.
All right, I think that's all the questions we have. It's 8:07, so I'll stop it there. Thank you so much, Dr. Ocuin. Everybody, we're off next week for Thanksgiving, but we'll see you all on December 4th.
Great. Have a good Thanksgiving. Thanks for having me.
Yeah, thank you.